here to talk about FIT today, and I brought with me Seema Chaudhari, who is one of our GP leads and who does all of our FIT work now, and Ed Seward, who you know is a gastroenterologist and has talked, Ed and I have talked to you for many years about FIT, Amelia Robson, who works with us in the primary care team at the Cancer Alliance, and I think James Harris is probably joining us now also from the Alliance. And Emma Boyle is with us to make sure we kind of stay online and you can see everything. So do you want to share the first slide, please, Amelia? Great. Okay. So this is what we're going to cover today. We've got a quick overview, and then we're going to hear from Ed talking about tips and support for using FIT and what FIT's about and the data around it. And then Seema's going to talk to us about using FIT in the primary care environment and how taking the learning from feedback we've had from practices and feedback we get from from the laboratory. She's going to also talk about give a repeat overview of the things like the right kind of pots and all the rest of it. Okay, so next slide, please. We'll have a Q&A at the end. Okay, so again, for many of you will have seen the slide, we're the North Central London Cancer Alliance, and we cover the same boroughs. We're continuous in geography with NCL ICB, and we do now we exist as one of 21 alliances and sit between the hospitals, their research units and primary care and the wider ICS to do the best we can for cancer in our area and to identify innovation that's appropriate for bringing into practice. So thanks so much for being with us today. I think we're going to move to the next slide and I'll be able to hand over to Ed, I think. Okay, Ed. There we are. Are you okay with this?
That's great. Thank you very much, Claire, and welcome everyone. And really, this is just to fill you in a little bit more about FIT, although I'm sure you're all familiar with it on a sort of day-to-day basis. So obviously, it's a very specific and sensitive, certainly a sensitive test and quite specific for the presence of blood in the stool. And patients like it because it's relatively straightforward and it's just a single sample. Prior to us using FIT, of course, we relied on symptoms, and really the most important thing to say about symptoms is they are pretty rubbish at anticipating the presence of cancer. You're probably aware that the NICE guidance was that they took a 3% threshold. So if you had symptoms that suggested a greater than 3% risk of cancer, then that was enough to get you onto 2-week wait pathway. Actually, performance, I don't know about NCL performance, but certainly at UCLH, we had a 2.5% conversion rate of colorectal cancer on the colorectal pathway. So symptoms were performing very badly as a way of sorting out our patients. And of course, the effect that has to a gastroenterologist like me is that we end up doing a lot of normal colonoscopy. And of course, it won't surprise you to hear that colonoscopy capacity is a real challenge. You know, we're busy like every other sector of the health services. And so any way that we have of sort of honing in our scarce resource to try and find a more specific group of patients is really useful. So FIT has been great. Next slide, please. And so what's been established is the fact that, and this is with meta-analyses, is that if your full blood count is normal, the examination is normal, and it says here a negative FIT, strictly speaking, we're meant to say FIT below threshold, then you have a 0.1% risk of having colorectal cancer, which is basically that of the general population. And the example that FIT and aficionados use is that if you had a sort of husband and wife in your clinic and you were chatting to the husband about his colorectal symptoms, if his FIT test is below threshold and the full blood count's okay, then doing a colonoscopy on him, you might as well colonoscope his wife at the same time, because they carry the same risk. So somebody without any symptoms at all. So FIT is incredibly reassuring, and we might get a chance to talk about a sort of early analysis of the FIT less than 10 pathway that we've been running in NCL, but I can certainly reassure you that that data also seems to suggest that FIT is a very reliable way of excluding colorectal cancer. The target we've been given is that 80% of lower GI referrals need to be undergoing a FIT, and we're going to see the data in a second for NCL, but really this is a point we need to hammer home, is that really as many as people as you can need to be having a FIT test, because it's so useful in terms of determining whether cancer might be an option or not. Next slide, please. So this is some data really just showing relatively old data now in the sort of FIT work, because FIT is such a new test. 2016 is actually going back some, but this was looking at what were the best contributors towards anticipating the presence of colorectal cancer. And FIT, as you can see from this, FIT was as useful as finding a sort of craggy rectal mass on PR in terms of anticipating the presence of cancer. And all the other things that we think about, like symptoms, change in bowel habit, rectal bleeding, even anemia, FIT far outperforms these. So FIT is a really good test for trying to act as a determinant for the presence or absence of colorectal cancer. Next slide, please. And you can also do a ROC curve. And for those of you who remember your medical statistics, the red line is in essence the performance of FIT, and the closer that line is to the y-axis, then the better the test is performing. The blue line in this case is the old NICE criteria. So this was a symptom-based criteria that got people onto a 2-week wait pathway. And in essence, symptoms are basically, you might as well flip a coin to decide if somebody has cancer or not, whereas FIT performs incredibly well. Next slide, please. Now, one big advantage that we have in North Central London is that there's a big study which has been done on our population of patients, and Claire and I were involved in a study group that looked at the performance of FIT in the NCL region, and it was elsewhere as well, but NCL was by far the biggest contributor of patients. So this is data that you can rely on, because this is data that reflects the people that you're seeing in clinic on a daily basis. And obviously there's quite a lot of information there, but just to draw out things, it's got a very high negative predictive value. As I say, subsequent meta-analyses have actually suggested that it's actually much better than this. But it's certainly a very reassuring rule-out test. And happily, on point 2 here, about 80% of the patients were below threshold. So if you're picking 10 as your threshold, then about 80% of patients were less than 10. And of course, that's great news for me because of my issues I have with colonoscopy capacity. So I can start concentrating on other groups to look at, such as bowel cancer screening. And that's something that you'll be aware that we're bringing the age threshold down for bowel cancer screening. We're currently at about, I can't remember if it's 52 or 54, but that's coming down towards 50 as we speak. And we're about to start a FIT, dropping the screening FIT threshold from 120 down to 80, which will obviously make it a much more sensitive test. And again, that's better for our local population. And we can only do that if we're making space on the symptomatic side of the pathway. And then what does this do to our positive predictive value? That's okay. It increases it from 2.5% to about 10%. So we're finding a 4-fold increase in colorectal cancers in those people that we're scoping on the urgent pathway. And of course, that's great news. Sorry, Amelia, go for it. So the next two slides are just looking at our performance in terms of, are we able to get our patients, are we hitting that 80% threshold that NHS England have set for us? And you can see that this is quarterly data. So you can see that Barnet are leading the pack at 80%, but then the rest of the patch is doing well, and clearly there's been improvement. But I think you can probably see in the last quarter or two, it seems to be we're at risk of slightly tailing off. So this is, I guess, part of the big message from this talk is please do not ease up on fit, because it's great for your patients because it gives them an accurate idea of what's going on, and it's great for me in terms of managing my colonoscopy capacity. Next slide. And this is just looking at the same data, but this is what NHS England looks at. This is monthly data, and you can see NCL ring there, and we're doing pretty well, but it's not perfect. And I get the fact that not everyone is going to be able to do a fit, and there are a whole bunch of reasons, and we can maybe talk through that in the Q&A at the end. But we're not perfect, and we can do better. So I would just encourage everyone to do their very best to get their patients to have a fit before they get referred up. Thanks very much. Seema, handing over to you.
Hi, hi everyone. Nice to have you all here. Just as an introduction, I'm a GP working NCL, and so I'm going to be speaking to you about how we can support our patients to do fit tests, and getting them quickly back to the practice so that we can act appropriately on the result. So firstly, I'm just going to be discussing about some practice protocols. So we've created a sort of a useful flow chart here, which can be used as a sort of aid when clinicians are consulting with patients who are presenting with possible bowel cancer symptoms, and it's just a useful tool to sort of take you through the flow of where you would go, and importantly, it's got sort of exclusion reasons, so reasons why we wouldn't do a fit on a patient, and that's rectal mass, anal mass, and anal ulceration, because that group of patients would be straight away referred on the suspected lower GI pathway. But in all other cases, we would be doing a fit test. And so this flowchart just takes you through. It's also got in here some information about safety netting, which in a few slides, I will talk a bit further about that. And it's this slide also has a useful reminder of the NG12, so that's the NICE symptoms for cancer referrals. And you can have this up in your clinic rooms or anywhere in the practice that you think clinicians can easily refer to this. Next slide, please. So this is also a really useful bit of information for clinicians. These are the exclusion codes, so the reasons why patients would not have a fit test requested. It's important to make sure that we as clinicians are coding these reasons. This is because when it comes to the Impact and Investment Fund that monitors how we as practice and PCNs are doing with this indicator, this search will actually look for these exclusion codes. And so we want to make sure that if a patient has one of these reasons, that the system, which is very sort of black and white and automatic, will pick up that that patient didn't in fact need a fit test, and so it's not going to wrongly sort of penalise the practice or the PCN for not doing a fit test on that patient. You can also take this away and put it up in your clinic rooms or wherever else may be useful as a sort of a helpful aid when seeing patients. Next slide, please. So in the next few slides, we're going to have some information on safety netting and setting up text message reminders. We have a bit more information in the appendix on both of these things. Next slide, please. So this is the electronic safety netting that some of you may already be familiar with. We use this electronic safety netting template in safety netting our cancer referrals. And you will see on the left-hand side column that it is the direct access diagnostic tab that has been selected. So we can actually safety net fit test results, and it's useful to do this at the point of requesting a fit test. So we can put in a diary entry for a week or 2 weeks or whatever it is that you want to select and feel that that would be an appropriate time frame for your patient to bring back that test and get a result back. And so that will aid as a diary alert, with a lot of practices, they will the administrator will run a search for these diary entries. That's also an important step to make sure that your administrator is running these searches, otherwise the dates won't get picked up. But I think that most practices using this template will be doing that. And this is also really good at just safety netting, making sure that patients' test results come back, especially in such an important decision such as this. The full guide to this is in the appendix. Next slide, please. This is also another way to safety net patients bringing their fit test sample back to the practice so that we can send that off to the lab. So this is a text message reminder that you can get through AccuRx. This template has actually been set up in conjunction with NHS England, and when you type in fit, you'll find that there is one preset one. I think it's something like fit test. I can't quite read it there, but it will be very obvious on the AccuRx. And you get 2 text messages, one that will go out straight away to the patient, and one that goes out a few days later. And that few days later is the really useful one, where it will again remind patients to bring their fit test sample back to the practice so that we can send that off to the lab and get a result back ultimately. And there's more support through that link on this page. Yeah, thank you. Next slide, please. So other tips for fit test results in the practice. Best practice, as you all know, is making sure that we get a fit test result in order to make a decision about a suspected lower GI cancer referral. Patients should be told about how to complete a fit test and offered a patient information leaflet, and ideally that leaflet in a language that the patient understands. So coming up in the next few slides, I can signpost you to a page where it has lots of foreign languages. Practices should also establish the safety netting processes, the electronic safety netting processes, and ensure that staff and clinicians are using them. And also practices should just make sure that that they've established the fit code matching process. So this is just to make sure that fit test results that come back into the practice from the lab do have the correct SNOMED code attached to them. we ran a couple webinars earlier on in the year about this, and there is some information again in the appendix. But if you as practice are finding this difficult to find out, then please do get back in touch with us. We can help with this. Common issues to be aware of. So ones that we've found while speaking to practice and PCNs, some often fit tests are requested at the same time as referral to the suspected cancer pathway. So you won't get the fit test result back, and therefore you won't be making a decision based on the fit test result. And ideally, this is what we should be doing. Wrong container is handed to the patient, so making sure that it's a pale green topped slim container. Making sure that the sample container is closed and doesn't leak, making sure that it clicks to close. If the fit test sample container isn't labeled or it has incorrect patient information, the lab will just automatically reject this, and unfortunately we won't get a result back. And if the fit test results are coded incorrectly, which you can find some further information in the appendix here. Next slide, please. So just a picture to make sure that we're all giving out the correct fit test container, which is the middle one, pale green, slim container. It only needs a very, very small sample, and the patient information leaflets will have a picture to kind of illustrate this. Next slide, please. And next slide. Great. So on this link here, under patient information leaflets, it will take you to a page where it's got loads of patient information leaflets for fit test instructions. I think at least sort of 7 or 8 languages. And additionally, NCL Cancer Alliance have created instruction videos for patients to watch in order to give guidance on how to take a sample for a fit test. And those instruction videos you'll find both in English and in several other foreign languages. So please use this. They are really, really useful. Next slide, please. This is a image of the patient information leaflets, and that the link on the previous slide has leaflets in lots of languages: Arabic, Bengali, Mandarin, Gujarati, Hindi, Polish, Punjabi, Somali, Turkish, Urdu. So lots and lots of languages there. Next slide, please. And this is just a really useful poster to have up in perhaps reception or even in the clinic rooms, just as a reminder of the type of fit test, the type of container that the fit test needs to be done in, and just all the steps that we should do from the practice end to make sure that we have enabled and supported the patient to complete the fit test properly and in as quick a manner as possible. So please feel free to take this away and put it up in your clinic rooms or in reception or wherever you feel may be useful. Next slide, please. Thank you. That's everything.
Okay, that's great. Thank you so very much. So we've got through the main slides reasonably quickly. There are lots more on the in the appendix that you might want to go through, one by one, that are constructed like series of screenshots to help you do the various things that we've talked about in the webinar. Now I'm just going to have a look at questions, and thanks for putting that in the chat. Have you got that now, Karen? The one on Accurix? You okay with that? We did, yeah, okay. Okay, so Karen, tell me you can't see it, or you can't, or because it's within, I think, do you want to bring up the slide, Amelia, for that? Okay, so while we're just waiting, is that there? Yep. I wonder if anyone's got any questions about fit or experience that they've met in practice. And if anyone's, I don't know if it's I can't see people's hands or just shout out. I think I haven't got any hands up at the moment. Do people find it a problem using fit as the starting point for the pathway? So what we often find is that people have sent, as Seema said, has referred a patient at the same time as doing the fit, and so they're not really acting on the fit test. I think now that Ed's here, I might ask. People often do that, Ed, because they're worried that it's causing delay if they don't send a patient off without fit. But in most situations, in terms of particularly considering the speed of progression of bowel cancer, which is reasonably slow in most people, do you can you reassure everybody that it's fine to wait a few days for the fit test to come back, or do you think differently?
I mean, completely. I mean, certainly it's quite interesting for me watching Seema's part of the presentation, just seeing how much technology is available in terms of supporting use of fit, and that looks quite reassuring to me. Whereas I think when fit first came out, we were concerned that it's hard, isn't it? You see a patient with worrying symptoms, you do a fit, and then you have to wait on the result to come back to you. And if the patient doesn't do the result, then maybe you have to safety net them somehow, and all the rest of it. Whereas now it looks like we've got the technological answer in terms of managing that in a much safer fashion. In terms of waiting a couple of weeks for the patient to do the fit and then for the result to come back is obviously meaningless in terms of cancer progression. It won't make any difference at all. So I would definitely reassure people that waiting for the fit result is really important, just because it does then give us the opportunity to better focus our colonoscopy resource on people who really need it. And it'd be nicer to do less normal colonoscopy and more colonoscopy where we're finding cancers or very big polyps.
Yep. Yeah, so using fit really allows us to concentrate the likelihood that we're going to increase the likelihood that we're going to see patients who've really got disease, Ed. Yeah, yes. I've got Ian from Eagle House Surgery. Ian, do you want to speak your question? Or did you put it in the chat and I can't see it? It's easier if you speak it, if you like. Got your hand up, I think. I'm not sure. Ian, can you hear us? We can't hear you. Not sure whether. I think your mic might be off, according to the little picture I've got. I might want to put the question in the chat, maybe. Can anyone see it? Okay, don't worry. You're all muted. Okay, so maybe whoever's... Emma, can you have a look and see if you can take people off? Because the mics are all disabled. Dear me, sorry, we didn't mean to do that at all. But what if you click on them?
Yeah,
is it
that's
still
better. Can you hear me?
Fantastic? Yeah, and now I can hear you. Thanks so much. Brilliant. Thank you.
Also I can't turn without my
can't
lovely
what?
features. So
you can't turn the camera. Don't worry.
yeah. Okay. So oh God.
Let me just see that then. Do you think that's us that's taken off the cameras?
Oh yeah, that's better. Yeah.
Can you just make sure, everybody, that Emma again, just make sure we haven't done something funny with the cameras?
Yeah, I think you did actually.
Didn't mean to. Sorry.
So, one of the problems is about 10 years ago, we were castigated for not referring early. I was with the Transforming Cancer Services team, and we were all told, refer the drop of the hat because, we need to get more and more things going. Okay, that was before FIT and things change. But the other problem is GP is now so underfunded and chaotic that, and we're so busy as GPs, that if you've got the patient in front of you, it's so hard we're following up everything. So one of the things, and I'm sure GPs know that, is it's actually safer from our point of view to do the referral first off and get everything sorted out at the end. And there are enormous delays at all sorts of ends. Things go missing, people drop off specimens. They don't, God knows what happens. Sometimes the lab loses them, sometimes the patient gets confused. And we've got systems. I mean, I've done a customized spreadsheet we use to follow people up. But even then, it's still hard to get people to do things. And in between chaotic patients' lives and their chaotic health service, I think all GPs feel a bit worried. I mean, I do. And I'm very sorry. I know you're doing colonoscopies, although I would point out that in a lot of countries, they do screening, not just fit. I mean, the one well-known local colorectal surgeon complains that we're not doing colonoscopy screening. And of course, in some areas, they do hemicolonoscopies, don't they? Like in Northampton, but they'll do hemicolonoscopies routinely for people over a certain age.
Let me bring in Ed, and so that you've got several questions there, Ed. Do you want to?
I mean, I'm probably best. It might be Claire, you or Seema want to speak to this as of the sort of GP side of it, but I completely get that, Ian. I mean, you won't surprise you to hear that. I've been in fit really from the outset, and that is a really common comment I hear. And I suppose as a sort of ivory tower tertiary referral gastroenterologist, I don't really have an easy answer for that. But I am very reassured by Seema's tech, I must say. But with respect to things like other tests, I mean, ideally, yes, a screening colonoscopy would be fantastic, but NHS just can't afford it, and that's straightforward. Bowel cancer screening used to run the Bowel Scope trial, where every 55-year-old got a FlexiSig. And actually, interestingly, that was the intervention with the best evidence in terms of avoiding colorectal cancer in the future. But that was sacrificed when the pandemic came along, with a view to bringing down the age for bowel cancer screening through FIT. So it was always a bit unpopular, to be honest. It always felt slightly unsatisfactory, going a variable distance up the left side of the colon. You're not looking around the corner, obviously, to see if there was anything else going on. The views weren't great. It was all a bit unsatisfactory, to be honest. So so that's been junked. So the data was from Nottingham, which is probably what you're thinking of. But that's not practice anymore in the UK.
Right.
The other thing is that life changes, we move on, that things develop. And so although it's really difficult, that the messages, I agree, Ian, and I've worked with TCST as well myself in years gone past. So I remember all that we were saying and the messages that we were giving out. But essentially, the technology has changed, and the way we understand the best use of FIT has changed. And I think we're in the right place now. It's better to use it at the beginning of the pathway. And it's really helpful to have it firstly in primary care, so that you can use it as a diagnostic tool yourself, or a rule out tool, depending on what the differential diagnosis is with the individual patients. And it's also really helpful when you do refer in, particularly on allied pathways like the non-specific symptom pathway. So I'm going to bring in Saloni, who's joined the call. I work with Saloni in the Middlesex doing non-specific symptoms, and I just messaged her in the middle. This isn't a set up thing. I messaged her in the middle of the webinar saying if she could explain a bit about what happens when people come into us with non-specific symptoms and they haven't yet got their FIT result, and the FIT result hasn't been used in general practice first. So Saloni, can you talk a bit about what your findings are and how you think it's helpful for us to manage in primary care when we're feeding into the non-specific symptom pathway?
Hi, Claire. Thanks very much. So I work at the Rapid Diagnostic Centre in North Middlesex, which is one of the 2-week wait clinics. So we're on the receiving end of the referrals for the RDC. And the most challenging part of these referrals is not having the QFIT available to us. largely because then we have to try and arrange it with the patients. They always find it very hard to come back to the hospital to drop off their Q-fit, and that tends to be a delay. Often we try and ask the GPs to send the results if sometimes we can't see it or if it's not available on the HIE. And a lot of the time, when the result does come, there has been a delay, and then we've noted that it's high. And then they go on to have their colonoscopy, which may be 6, 7, 8 weeks down the line, with an unnecessary delay. And sometimes we have seen colorectal cancers come out, and that's been sort of 2, 3 months later by the time we've got the sample and then arranged the investigations. And we really feel it's not really in the patient's best interest to have delays in their obvious diagnosis. So it would be really, really beneficial if we could have all the Q-fit results. And I appreciate it's difficult to get the patients to return them, but if we could really be mindful of sending the fit results through, then that would be great.
And I guess in the scenario you're describing, when, and obviously we work together, so we have similar experience. If in primary care you're doing the fit and it comes back more than 10, then that patient isn't appropriate as first off to the non-specific symptom pathway. Where they need to be first is the colorectal pathway, and then the colorectal, from there will flow other things. And if there's something outstanding after that, then by all means send them to the non-specific symptom pathway. But it's really much faster for the patients if we can get them into the right place as quickly as possible. So that's a real kind of life example of where it's really helpful to try to persist with, albeit the challenges that Ian and others have, that I know that people feel they face. But it's really, really helpful to get the result in primary care and use it to decide where you next go on the diagnostic pathway or management pathway. I've got a question from Mansuka Shah in the chat. Ed, this is moving on to inflammatory bowel disease, and says, can we patients with inflammatory bowel disease often have blood in the GI tract, so how do you screen these for colorectal cancer?
Yeah, so FIT is actually a really good test for IBD. It has been, there are a couple of studies that have looked at it, not for a while, but a fecal calprotectin is a relatively expensive test, whereas FIT testing is dirt cheap. And there are certainly resource poor areas where they use FIT to screen for IBD as well as cancer, obviously tends to be in different populations, but 100% a proportion of patients with positive FIT or FIT above threshold, will have IBD, and so they're quite important to focus on. If a patient has known IBD, then they should be under a surveillance pathway anyway, unless it's just proctitis. If it's just proctitis, so proctitis carries no increased risk of colorectal cancer in the long term. So if you have a patient with proctitis who has symptoms, then FIT probably is fairly useless. But the majority of those will be under a GI team anyway, and I would definitely get them to contact the IBD CNS that is responsible for their care, or you can do an advice and guidance to the team, and in essence we'll do a colonoscopy in that sort of situation. That's one exception where FIT isn't particularly useful.
It brings up the other point that I know that we've talked about before, Ed, and some people think it's, or certainly patients think it's odd, but when they do a FIT test, there are lots of reasons why people have blood in their poo. They might have piles, they might have something else, or all sorts of things. It's really important, isn't it, to ask them not to sample a bit that's bloody, but to sample a bit of feces that is just brown. Is that right?
100%. So when FIT came out, the perception was that it would not be useful in a patient with PR bleeding. Now, if you go to the study that I referred to, that Claire and I were involved with, actually PR bleeding, FIT worked just as well in PR bleeding as it does in change in bowel habit or abdominal pain or whatever. And so it's all about counselling your patient to say you either sample a non-bloody stool or you sample away from the blood, and then FIT will perform as well as it does in any other clinical scenario. So there is this perception that it doesn't work in PR bleeding. That's a false perception, but you do need to tell your patients that. And often I will, if I'm scoping a patient and they had a really high fit and they got massive, great big hemorrhoids, I said to them, "Oh, do you get symptoms from these hemorrhoids?" "Oh yeah, I bleed all the time." "And when you did your fit test, did you donk it in like a big lump of blood, or did you say, "No, yeah, I shoved it in the blood"?" And it's like, well then, and the patient realizes as they say that, actually, yeah, that's probably a dumb thing to do, wasn't it? So it is just a question of informing the patients that clearly if you stick in a load of fresh blood, it's going to render the test meaningless. So do counsel your patients. That's really important. And then it's not come up in the chat, sometimes it does, but about what to do with young patients. And what I always say, a FIT test is you use it in a situation where cancer is on your differential. And if you think, okay, they're 38, they're pretty young for cancer, but I hear that bowel cancer is more common in younger people, I'm going to do a FIT test. Totally reasonable. Youngest person I've colonoscoped on a 2-week weight pathway with a positive FIT was 17, and clearly bowel cancer in a 17-year-old is insanely rare. Now, surprise, surprise, he had IBD. So calprotectin in that scenario is much more useful. So it's really where the relative likelihood is. Ian, you're going to tell me different. I can feel it.
No. I want your expertise. I've always been a bit confused about FIT in terms of you're detecting the breakdown product of blood, like the myoglobin, aren't you?
No, you're detecting globin.
Globin. Okay. So does it pick up fresh blood? I was told that it actually doesn't pick up if it's fresh bleeding. It won't pick it up. But you said it does.
That's not true. Yeah. So it's an antibody against the globin moiety of the hemoglobin molecule. Yeah.
Right.
So
okay.
Fresh, old, you name it.
Okay. What about? I mean, would it detect bleeding from digested blood? Then it won't from the stomach.
Well, there's a really interesting study from the States where they looked at a whole bunch of patients who had FIT above threshold and normal colonoscopies. And fascinatingly, in that group, they had a slightly higher risk of upper GI cancer. So the suggestion is that presumably if you're getting enough blood leaking through, then maybe some of it is undigested by the upper GI tract, and then that will trigger a positive FIT. Now, that said, just to be clear, because I'll get into so much trouble if I don't say this, we don't need to do OGDs on patients with positive FITs who have a negative, a normal colonoscopy, but it is interesting. I've diagnosed one small bowel adenocarcinoma, which in itself is phenomenally rare, but he had a positive FIT and a normal colonoscopy, and then he had more tests for whatever reason, and we ended up finding a small bowel adenocarcinoma. So really rare, but there is some suggestion that you might get some blood tracking through from the upper GI tract, but in general, no, you don't have to worry about it.
Okay, thank you.
Thank you. And Lisa, I hope that's answered your question. You might just have a quick flick through the chat, Ed, so you can see her question, but I think essentially it's the same. So if you're bleeding from your hemorrhoids and you put the stick in the blood, Lisa, the QFIT will be above threshold. And if they put it in a bit of the feces that has no blood in it, then it should be negative. Clearly, sometimes things get contaminated and you have to make allowances for that, but it's still appropriate to test people when they've presented to you with other symptoms that don't fit with simple hemorrhoids. It's still appropriate to test them with a FIT test. Okay, I'm just going through the questions now. Okay, so let's do the last question I can see in the chat at the moment. Then we're going to go back to Gallery. So we've got a question from Hilary around the Fit Less Than 10 pathway. So I think James is on the call, but if we let Ed start off, and if there's anything else you want to add, James, then wave your hand. So Ed, do you want to bring us up to speed with the Fit Less Than 10 pathway?
So the idea behind the Fit Less Than 10 pathway, so at NCL, and it was probably slightly controversial.
We like to be controversial.
Well, and also I think it was my idea. So if you're going to blame anyone, blame me. The idea was that, thank you. We were worried that because FIT was relatively new technology, and there was an anxiety that maybe in real life, tons of people will end up having cancer who were fit below threshold. And so everyone thought that safety netting these patients was going to be a good idea. And we made a decision to safety net in secondary care, not because we lacked any confidence in our primary care colleagues to be able to do this, because of course you safety net a zillion things every day of the week. But basically, it was just the best way of collecting data, because we thought if we could concentrate these patients in secondary care, we could generate a load of data that would establish a safe way, a safe mechanism, a safe pathway for safety netting these patients. So that was the idea. And what we came up with was the idea of, so about 8 weeks after referral, or their first fit, you would do number one, a second fit, and you would repeat the full blood count. And the idea being that if the second fit was above threshold, then they would get investigated, they get a referral. If they developed anemia, then again you would refer them. But if everything looked okay, then that was probably going to be super reassuring. And interestingly, the data caught up with us. And there's been subsequent data showing that if a first fit below threshold is reassuring, a second fit below threshold is about as reassuring as you can get. And you have something like a point, I think it's a 0.0004% risk of having colorectal cancer if you have 2 fits below threshold. So second fit below threshold, super duper reassuring. Now, so that was
8 week, but we had a timing, didn't we? And there's been a time in that, about
roughly
8
weeks
separation. Yeah,
roughly 8 weeks. And that was the reason we chose 8 weeks, was we thought, well, look, let's assume the worst and the patient did have colorectal cancer. 8 weeks is probably not a disaster. So it was sort of based on that's where the figure came from. But clearly you could safety them 4 weeks, you could probably safety them slightly later. But anyway, that was the plan that we decided, and it was run by the colorectal service. So it was surgeons rather than physicians. And the surgeons said that they wanted to do a face-to-face so that they could do maybe a rigid sigmoidoscopy just to document the fact that they had big hemorrhoids or whatever. So that was all fine. We have data on that, and I don't know if I'm allowed to discuss it, but I'm sure I am. Basically, the data is really reassuring that a second fit is, in essence, we weren't missing any cancers. Is the outcome of the analysis that we made, and but we will be crunching that data properly, and then we'll get that out to you. But it was all really reassuring. So then the question is just to actually address your question, Hilary, is it still operating? Yes, it is, but it might not be operating for much longer, and a decision needs to be made. We've been really reassured by the data. Everything looks like it's okay, and that this is probably the way you might want to consider safety netting these people. So then what's the purpose of dragging them up to secondary care? And why don't we just then follow the normal route of being safety netted in primary care? But that decision has not been made yet, just to be clear.
Yeah. Okay, another question here that looks good. Rosemary, are you happy to speak your question to try if you can, if your mic's working, or otherwise I can speak it for you?
Oh, sorry, thank you. My
Off you
mic
go.
is working.
Rosemary, brilliant.
I
Let's
was
hear
going to
from
ask
you.
if you have a borderline Q-fit, someone has been sort of seen for unexplained weight loss, but their CT cap is normal and have been discharged from the RDC, but the Q-fit, they don't have any upper GI or lower GI symptoms, and they're borderline anemic, but the Q-fit is 9, which is the upper limit of normal. Would you just repeat that in 8 weeks in the absence of, in such a person who's losing weight? Or would you refer direct back as a 2-week wait to colorectal?
Well, Ed, you can give your piece and then I'll add something about non-specific symptom pathway, or the other way around if you like.
Okay, I would safety net them with a repeat fit.
Yeah. Okay.
Yeah.
I should say a plain CT will pick up about 80% of colorectal cancers.
Okay.
So again, that's an additional reassurance for you, Rosemary. So it's not a bad test actually for bowel cancer.
Okay, that's helpful. Thank you.
I think the other thing, Rosemary, is that these things are not in isolation. So when you do your repeat fit, you should be doing a bit of a blood profile as well. Maybe have a look at other markers, other inflammatory markers, or other things which indicate. We certainly see in the non-specific symptom pathway when we're really we're struggling hard to get a diagnosis. Certainly at that point, you can see quite a lot of different indices beginning to trend negative within the normal range. So you need to look for that and re-examine the patient always and see whether anything else is developing. And the other thing is being really, really sure that the weight loss is truly unexplained. So in our non-specific symptom pathway in North Central London, we're getting quite considerable numbers of people, for example, with undiagnosed anorexia or with an improvement in their blood sugar because someone's realized they've got poor control and give them a new medication. They're also then losing weight or, emotional issues, of course, and all the rest of it. I saw someone the other day who'd gone down from being about 75 kilos to 40 kilos, and their problem, they were in their 50s and they were very poor, and they had been poor all their lives, and the problem was their teeth. They couldn't eat.
Somewhere, just put the information that you want to put down.
Thank you.
Before we start typing it on the post and making it all pretty.
Okay, sorry, I missed who that was. Was that Melissa? Sorry,
I think it was Melissa, Claire. Yeah.
Okay. Hi, Melissa. What did you mean? What do you mean? Do you mean today, or do you want a Q&A kind of? Would it be helpful to have a Q&A summary out to people? Is that what you meant? Because you were talking about post-it note and I couldn't quite get that. Or was that a different conversation? Can't hear Melissa now. Can anyone else hear her?
I think that was a different conversation, Claire.
Okay.
We dropped in there.
We dropped in there. Okay, great. Okay, that's fine. That's fine. Okay, so we've got kind of 5 minutes left. You've been a really fantastic audience. It's been great to have this kind of conversation with you. I'm sorry that we messed up and took away the microphones and we didn't mean to. We'll have to just make sure we don't do that again. So, but I hope it's been helpful. Are there any kind of questions that haven't been answered, and likewise, are there thoughts that any of the speakers have got that have now come to mind that you think we haven't covered and we should do? Anything?
I suppose I will say, so there's a lot of work being done on this, and we're going to end up with a more personalised way of approaching fits. So at the moment, 10's an easy number, right? Anyone can remember 10, and that makes things very straightforward. But of course, life is more nuanced than that. And I think having the idea is that you'll probably have a risk profile, I guess the same way you guys anticipate your cardiovascular risk profile. You'll do the same with fit. So that's coming and should be coming very soon, actually. So next year, expect some really cool fit related stuff. Cool for if you get excited about fits, which I do. Possibly not everyone does.
Okay, never mind. That's fine. No, that of course we all do. That's great. Okay, thank you. What I'd just like to bring up now quickly, and it will be accessible afterwards. Amelia, can you put up our contact names? So if you've got questions and you're not quite sure and you want to reach out to any of us, please do. So we've just got a contact slide, and you can either, I think it's right the way down at the bottom. Have you got it, Amelia? But we'll try and post it we'll try and put it in the chat for you, so you can find our direct contact details if you need them. And if you speak to your colleagues and people want to, we think you come across lots of people who actually would like to have this kind of conversation again, then let us know and we can easily arrange it. Seema mentioned a poster for the wall about a flowchart for the management and also exclusion codes for SNOMED. If you've got something, Seema, that was what you may have been saying, you could make the details of what you put on that slide into a poster. Seema, what was your main aim of that comment?
We can send out that sort of flow chart. I'm not sure. Is there a plan to send out the presentation afterwards with the appendices after, so that the safety netting screenshots are also going out?
So we usually have them accessible. Emma, we will make it accessible, and the video of this will be on our YouTube channel.
Okay, great. Okay. So yeah, we can send out that flowchart poster along with the resources. Yeah.
So as a Cancer Alliance, we continue doing these webinars throughout the year, all sorts of different conversations and presentations on different days of the week, so that everybody gets a chance for some of them. And if when we do presentations that people really say they want again, we're really happy to do that. So you just have to let us know. And then the other thing is we're always increasing our, we advertise in all the ICB sort of standard methods for our webinars, but we also have a mailing list as well. So if you want to be on us to contact you when we have automatically when webinars come up, then do please let us know, put something in the chat today or contact us separately. I think it's time to end because it's 14:59. I'll say thank you very much to everybody, to all our speakers, but also everyone who's joined us today, so that we can have, I think, a really helpful, useful conversation. Thank you very much, everybody. Thank you. Bye-bye.